Well, good morning, everybody. Thanks for asking me to talk to you on one of my favorite research topics, which is neuromuscular scoliosis and decision-making and outcomes, trying to improve the outcomes for this difficult condition. My disclosures, and this is a picture of my last trip to San Diego when I was a visiting lecturer for your annual meeting, and I got a chance to spend some time at Greg's house, and I think we have Bob picture there, and with Baruz at his beautiful house with Nasrin. So I have a lot of friends and fond feelings about San Diego and wish I could be there. If you're interested in learning more about neuromuscular scoliosis, the Harm Study Group has a great publication that Amr Samdani edited through TIMA, and it's on neuromuscular spine deformity. So it's a good resource to have, and we may be able to get you a PDF copy of that. So that's a good thing to have on your library. And it's really a tale of two deformities, I like to say, AIS versus neuromuscular, because they're really opposite in a lot of different ways. AIS patients are neurologically balanced. They can hold their shoulders and pelvis level using their own balance systems and muscles. Their main goal is to look better. They have low risks of any kind of interventions, including surgery, low infection rate, and their function is so good that measuring improvements is limited by ceiling effects because of how well they're doing at baseline. Contrast that with neuromuscular patients who have little trunk balance from either brain reasons or muscle reasons, and their main goal is to sit better. They have poor tissue homeostasis. They're high risk of infection and even bleeding and death, and their function is so low at baseline, and their abilities to get better are so limited. They often have floor effects with most measurement systems. Neuromuscular scoliosis also is important as it's kind of gotten us to where we are in modern spine deformity. I like to say it's responsible for modern spine deformity surgery. And if you go back to Harrington days, Paul Harrington was faced with a big polio clinic in Texas when he first started practice. And that justified these large collapsing curves and pulmonary problems for these teenagers, justified the bold use of metal in the spine, because back then we didn't put metal in anything. Femurs, tibias, and especially not spines. So he started kind of having the justification for doing that in these polio collapsing curves. And then if you look at his initial reports, it's mostly post-polio, and a few AIS and idiopathics in there. And the gradual use and perfection of that simple system was the first long-term instrumentation system that kind of revolutionized spine surgery. Not only that, the use of pedicle screws at the bottom was the predicate use that got us out of the pedicle screw litigation nightmare, because he had drawn the use of sacral screws and the FDA had approved it. So going back and finding that was able to document that they had already approved that, and that kind of allowed us to turn the tide against pedicle screw litigation. The challenge of bleeding in neuromuscular scoliosis was also the first use of antifibrinolytics in their surgery, and that's a credit to Fred Shapiro in the use of Duchenne patients at Boston Children's Hospital. He borrowed that idea from the cardiac surgeons and showed that you could improve these patients' outcomes and decrease the blood loss by using TXA, or maybe a protein at that time, in these patients. So again, the challenge begets a good solution that is then generalizable to others as well. Neuromuscular scoliosis is the second biggest category of things we take care of in kids, with AIS and Scheuermann's being by far the biggest, but neuromuscular is directly below that, as you can see, followed by other things, congenital and syndromics as well. So what is neuromuscular scoliosis? It's any disorder impairing trunk strength and balance during growth, which gives a high likelihood of scoliosis, often at an early age. And these can be primary muscle disorders, peripheral nerve disorders, brain disorders, and other undefined disorders. So primary muscle includes Duchenne's, congenital muscular dystrophies, and polio. Peripheral nerves include Charcot-Marie-Tooth and SMA, if you include anterior horn cells. Spinal cord disorders include spinal cord injury, Friedreich's, and myelomeningocele. And brain disorders are CP, Rett syndrome, and leukodystrophies. So the indication for surgery is basically progression to a significant degree or risk of further progression. So generally, if the curve is greater than 70 degrees in an immature patient, we will operate. Or if the patient is mature at 50 degrees, we will know that they're going to keep progressing, so we will offer surgery. And the goal of surgery is to prevent pain, fatigue, and pulmonary restrictions, we'll talk about later. But you do have to be careful. In some patients who are higher risk or well adapted to their curve, it may be better to leave them alone based on the risks and difficulty of going through the surgery. We've done some investigation on the lung effects of neuromuscular scoliosis, and it's different than idiopathic curves. In idiopathic curves, you're focused on preventing rib deformity, angular rib malformations, and improving chest wall volume, which we've been able to measure with PFTs pre and post. In neuromuscular scoliosis, it's more about the diaphragm balance and the abdomen and diaphragm intruding into the thorax as the spine collapses. And our goal is to see if correction to these conditions improves the diaphragm position and improves the thoracic volume. So we've actually studied that with different ways. There's a program you can use to measure lung volumes from two-dimensional chest x-rays and compute it. Also, we looked at something called the diaphragm intrusion index, which is shown here, which is where the height of the diaphragm from T1 on one side versus the other. We also measured T1, T12 height and the diaphragm vertebral level. You can see on each of these x-rays, the parameters improve significantly by taking the diaphragm out of the thorax and improving the overall trunk height. So we looked at our patients at Hopkins, and from pre-op to maturity, the lung volumes, calculated lung volumes improved by nearly a liter from pre-op to post-op. So you're really doing, I think, a big improvement in the thoracic volume. But of course, mechanics are also important dynamically. The diaphragm intrusion index measure improved, and T1 to T12, T1 to S1 height improved as well. In terms of outcomes measures, in the EOSQ, there are several that are relevant. One is energy level, the other is self-reported pulmonary function, and the other is fatigue level. And the fatigue went way down, and the energy level and PFT went up in these patients from pre to post-op. So that's somewhat of a crude measure that their outcomes are improving and their quality of life from a patient point of view, it's improved. With these patients and their parents, we're often doing surrogate decision-making by the parents or whoever's their caregiver responsible party. And so we use shared decision-making to try to help them understand the risks and benefits and potential improvements that they can get from the surgery. And Eric Shirley has come up with this little diagram looking at reasons to choose surgery and reasons not to choose surgery, and letting them circle their preferences on a scale, a Likert scale from 1 through 5, and seeing how they kind of think through it. And so this is a way, it's also been used in controversial decisions like in prostate cancer, radiate versus operate, breast cancer, and so forth. So using this methodology can help them to work through it. But of course, you still have somebody else making the decision for the patient, which is an ethical problem for many people. Also, in order to subclassify the risks, especially in cerebral palsy, you need to look at more than just walking. The GMFCS is a neurological subclassification, which goes to 1 through 5. But there are patients who are stuck at 5, and they have many other impairments as well. Seizure disorders, lack of ability to speak, lack of ability to kind of keep their airway secure, needing a trach, and then G-tube due to reflux or feeding problems. And those are all different neurologic impairments. And we've looked at those as 0.1 scale on the scale of 1 through 5, and adding that to the GMSCS5 shows your risk of increased complications as you ascend in that subclassification scale. So the approach to the neuromuscular patient has changed a lot since I was a resident. Back in the 80s and 90s, the Minnesota group had said you should always go anterior and posterior in these patients to get the flexibility and to improve the fixation. But now new osteotomies and better ways of fixation and antifibrinolytics have changed everything. So in the harm study group database, only about 15% of patients have undergone anterior and posterior. 85% are done posterior only. And many times you can get a great result, as you can see here, from this pre to post-op, even correcting rotation as well as pelvic obliquity and increasing the trunk height. So posterior surgery is the way to go nowadays in most patients with neuromuscular spine deformity, to spare them another procedure and another increased morbidity. There is still a slight role for anterior and posterior in patients. If they're extremely lordotic, you can't really get that all fixed out from the back. Or if their curve is really quite high, such as this patient shown here. This patient had anterior and posterior stage procedure because of her lordosis and extreme scoliosis. And now she's a graduate student and she did well with that. Neuromuscular scoliosis often is fixed to the pelvis. And I think T1 upper thoracic to the pelvis is your most reliable deformity control. If you try to spare levels to help the patient, you may end up adding on later. So I think a high thoracic to pelvis should be your go-to plan. And here are some examples of patients who were fused short of the pelvis and then kept on curving, and sometimes quite substantially. I didn't do them, but I inherited them. And by the time they're adults, they're far too frail and kind of burned out to undergo a deformity correction, as you can see here. And the patient on the right, you can see, has S1 fixation, but no pelvic fixation. And even going down to the sacrum, it didn't control the pelvis and it kept on tilting in and curving over. So we think about going to the pelvis in most of these cases. And Dave Skaggs and Lindsay had a paper that I love the title of, typical Skaggs title. It said, don't you go onto the pelvis the first time? And the message was, if you have to go back and fix a missed pelvic obliquity, it's just as big a surgery as the first one. And you may end up with less perfect correction of the pelvic obliquity. So don't be afraid to go to the pelvis in these patients. Nevertheless, there are some patients who can safely be fused short of the pelvis. And those are the ones who have a high apex and you have plenty of leverage below that. So if the apex is above L1, or if the end vertebra of the cob is L4 or higher, and if they have active trunk balance, such as being a stander or an independent sitter, they may be able to self-correct and improve their balance. And the biggest predictor was high pre-op pelvic obliquity. If your pelvic obliquity pre-op is greater than 15, that tells you something about their balance system. And so they probably won't be able to balance themselves if you don't go down to the pelvis distally, post-operatively. So here's an example of a patient who's a stander and had a high curve. He was fixed down to L4 despite being a neuromuscular patient, and he did well. Here's a Milo wheelchair athlete, and she has minimal pelvic obliquity, and we fixed her down to L4, and she's still able to play wheelchair sled hockey and wheelchair basketball. So pre-op pelvic obliquity less than 15 degrees and some degree of trunk balance are your probably most important predictors. So there are different ways to create pelvic fixation, and some of them over time have been the unit rods, SEI screws, also called S2AI, and iliac screws with cross connectors. And we looked at the long-term results of those and published that in Spine. We found that unit rods and SEI screws, because they're kind of all one long system, tend to produce good and maintain it over time. You can see that over up to 5 years, there's very little loss of pelvic. If you look at the iliacs with cross connectors, they don't get quite as much correction and they tend to lose it over time. And the reasons that happens is that the cross connector will loosen, disengage, or break. And that is one of the things that limits your ability to maintain steady correction. And so you really need good pelvic fixation. This is one of my cases that's really still kind of, I marvel at that. This is a patient who had cerebral palsy. I fixed him anteriorly and posteriorly with instrumentation, got great correction. Here he was at age 19, but he wasn't still skeletally mature. But the distal screws were S1 screws. And he has continued, now he's almost 40 years old. He's continuing to crankshaft around that. And you can see his pelvis is way high. He's got about 35 degrees of pelvic obliquity, all because we didn't have good sacral fixation to help maintain the pelvic obliquity correction. The muscle forces are relentless and they keep on pushing over time. So he needs some strong metal as well as biological fixation to prevent that from recurring. The best fixation we feel is the SEI screws, because that gives you a long anchor. It can be over 10 centimeters long and up to 1 centimeter wide. And you can sink it into the sacrum, starting with the lateral aspect of the S1, the first sacroiliac, and you've got good muscle coverage, and you use it to crank the pelvis. You can distract directly against the screw, or compress up against it. So your corrective forces go right to that anchor. It lines up with the upper anchors in L5 and above. Implant density for neuromuscular patients often ends up being quite embarrassingly high. Many people put 2 anchors at every level. I don't really feel you need that. We looked at that in the harm CP group. You don't really need 30 to 40 screws. You just do 2 consecutive levels cranially and pelvic fixation distally, and you can skip every other level. You may need a few more around the apex if it's a lot of rotation. But in general, you can do a much lower density construct and save time, blood, and money as well. And the harm study group has shown that. Several other papers have shown that as well too. Another thing you don't need is crosslinks, because the pelvis and all these other doubly fixed levels are their own crosslink. So you don't need another prominent thing, a prominent piece of metal to maintain your curve correction. Bleeding is also higher in neuromuscular scoliosis. We studied that looking at our patients in different etiologic categories. If you compared AIS at the top, Scheuermann's, cerebral palsy, syndromic scoliosis, the neuromusculars actually are the highest group with the highest standard deviation. And we don't know exactly why that is. It probably has something to do with the intrinsic and extrinsic pathway and the quality of the muscles as well. So you need to anticipate that. Make sure you have blood available. Don't hesitate to transfuse if it looks like it's kind of necessary early on. And use a skilled second assistant. Consider using a bone scalpel, irrigating bipolar, and all those things together can hopefully keep you out of trouble. Because some patients will actually even have a cardiac arrest intraoperatively. Neuromonitoring is challenging in the neuromuscular patients. Transcranials are obtainable only in about 75%. If you look at some of the CAT scans, it's not a mystery why. You can see that there's no cortex in the usual area in this patient because of his severe hydrocephalus. And so you have to kind of be able to anticipate that. Make sure you get good baseline motors. And sometimes I will actually put cervical descending motors. If you leave enough of the cervical spine prepped out of the field into the field, you can put percutaneous electrodes down to the lamina and get good descending maps that way. And so that will often keep you out of trouble. It's not true to think that just because they're not walkers, you don't need to have to protect their spinal cord, because they need to be able to pee. They need to be able to feel their sitting surfaces and avoid pressure sores. So paraplegia is a disaster in some of these patients, and you shouldn't treat it cavalierly. Complications are also higher in this patient population, and they get a much higher infection rate. We know AIS and adult scoliosis surgery is about 1% risk of deep SSI, but in the neuromuscular patients, it's as high as 13%, as Stu McKenzie has shown, or at least more than 10% in other series. It's also polymicrobial or gram-negative much more often than in idiopathics. And I think the reason for this is really just the quality of the muscle. The muscle is tight, stiff, it's often denervated. It's not a good flap to put over your implants. And especially in patients who have paralyzed muscles, that muscle is just not a good envelope to go over. And the urinary and fecal colonization are often blamed for the gram-negative, but I think probably it has more to do with other things as well. So the implication is use broad-spectrum prophylactic antibiotics, ANSEF and GENT preoperatively and perioperatively, and make sure you use that in your local wound antibiotics as well. I usually use a drain in these patients, although I don't often in idiopathics. I also use a wound vac as well. So why is the SSI rate high? I think it's the muscle, as we said, tight, stiff, and poorly perfused. And so sacral coverage is the worst example of that. So when you're stripping the muscle off the sacrum, you often have a much thinner muscle envelope, and you're traumatizing it with your retractors, and it often doesn't even sew together very well. So why the high gram negatives? I think it's probably has something to do with not so much outside in contamination, but probably inside out from gut permeability. Because we know that when people are hypotensive intraoperatively, their gut will leak, and gram negatives can become bacteremic as well. We're trying to work on seeing whether that is a provable hypothesis, but I think that's why. So local antibiotics and wound vacs. And Sook and Shah's group showed that by using local antibiotics, by broadening your spectrum, you can decrease the wound complication rate by a significant amount. So over time, we've tried to do a lot of process improvement to improve our rates. And we studied that over the harm study group, which has been going on for 15 years now in the CP population. We found that process measures improved, but the outcomes did not improve. So duration of intubation is less, hospital stay is less, bleeding rate is much less due to antifibrinolytics, but the SSI infection rate is still kind of hovering about the same and not significantly better. So I think that's a host factor that's not at least modifiable with current techniques, and hopefully we'll come up with some genius ideas to help decrease that. So specific conditions, Rett syndrome, as we said, is a high incidence of scoliosis. About 60% will get a curve, and about 11% will need surgery. They're often ambulatory. The thing about them is they have seizures and they have poor pulmonary reserve, much higher need for reintubation, longer intubation durations. So that's the key thing to anticipate with those patients. Friedreich's ataxia is something that often is missed because they start out normal and they develop their signs of the neurologic disorder right about the time they need surgery. Here's an example from my practice. A boy whose sister had posterior spine fusion, and I thought he had idiopathic as well. So I did a PSF in him, stopping at L2, and I was very proud of myself. But in the 6-month follow-up, we came back with significant trunk decompensation. He was also starting to have some slurred speech, and it became evident that he had a dysarthria and eventually diagnosed with Friedreich's ataxia. So we had to take him down to L4, and thankfully he did well. But earlier recognition of that kind of stuff is important. Duchenne muscular dystrophy was often the prototype for the biggest challenge in neuromuscular scoliosis. But steroids now have cut the scoliosis incidence by about 50%. And so typically we don't operate on these kids until their curve is much bigger, because many of them will just kind of end up staying well enough controlled. And you can improve the bleeding rate by TXA or Amicar. Myelomeningocele has the highest infection rate of all. Some report up to 25%, and that's because the muscle is tight and denervated, and they were born with a big hole in their back that we try to yank together when we close them. They're difficult to monitor because they're typical anterior tib and foot muscles are not monitorable, so you have to rely on the quads. Infection is an issue and pressure sores are an issue. So I like to recommend anterior-only fixation and fusion for some of these patients to stay out of the back in many cases. This is a patient who I did anterior only, and he's been stable. So so that's myelomeningocele. And some of these patients actually do okay. They're well enough compensated. This is a girl that I've followed since birth, and she looks okay when you look at her. She's a wheelchair athlete. You can't really tell that she has this big curve on the x-ray, but she's functioning well without fusion, and she has never come to a spinal fusion despite having a 70 or 80 degree curve. SMA develops large curves at a young age. Magic rods do well with the kids, and you can often just let them stiffen in place without doing a final fusion. And nowadays with the rescue drugs they have, they tend to do better with their hips and with their upper extremity and live longer. So that kind of is a run through the spectrum of neuromuscular scoliosis. And the take-home points are these are bigger challenges. Just because it's an idiopathic, a non-idiopathic, don't think that it's going to be an easier thing you don't have to prepare for. Progression is inevitable if the curve is greater than 50 degrees after maturity. They tend to have increased blood loss. They tend to get infected with gram negatives as well as gram positives. And muscle is the main culprit for many of the problems. So another interesting idea is one from Paris, France. Lot Pimolati has come up with this idea that we should ignore the apex and just kind of stretch them out, let them stiffen in place. He's come up with this bipolar self-lengthening rod that you put in from the top and anchor in the bottom, and it allows you to do a simpler surgery and stretch them out over time. They kind of self-grow, he feels, as they get taller. And so many of these patients are never given a posterior spine infusion. They use this internal brace and end up being controlled well enough. And it's a lower morbidity for the patients. I think it's catching on a lot in Europe and maybe headed to the US later. Does surgery for neuromuscular sclerosis prolong life? It's been shown that it does not. Does it improve pulmonary function? Possibly. Does it improve daily care? Yes, all of our studies show that. And if your always has shown our study group results for CP patients at 5 years, and on the validated CP child score, they have significant improvements in personal care, transfers mobility, and overall quality of life. So we still have to work on some of the issues like bleeding, high infection rate, and improving the risk benefit. But I think overall, with an experienced surgical team and a good pre-op evaluation, that you can improve the patient's results and decrease the risk of complications and help them to live a longer and more meaningful life. Thank you.